Within visit 2 or visit 3, at least in our clinic, I know if this is going to be a permanent impairment for this patient. I'm going to know if I have a rateable condition on this. So think about between a 5 to 25% whole person impairment rating, basically off a third visit. However, my goal is to rehabilitate this patient. That's my number one goal, is to rehabilitate and try to stabilize this patient.
That's Dr. Brett Chance, CEO of One Wellness RX and founder of Winter Park Chiro. He uses an objective data rescue protocol to identify measurable injury consequences that carrier AI often overlooks. By the third visit, his standardized workup can identify a rateable, whole person impairment that helps attorneys defend against degenerative coding and pre-existing condition arguments.
The record is no longer really just saying that the patient was hurt, it's just showing that the injury had measurable consequences over time. So that's what it likes to see. It likes to track progress through the coding strategy because it's data. Remember that. It's data, data, data. So coding strategy and the data input.
In this episode, you'll learn why carrier AI scores record structure, not actual injury severity, how Flexion extension views produce objective evidence most files are missing, and how a standardized workup identifies a rateable impairment condition by visit 3. I'm Jason Lazarus, and this is Trial Lawyer Review. So full disclosure for listeners, Dr. Chance treats me for athletic performance optimization. And when I get my neck or back screwed up from driving my car too fast, he's there to help. And we've always talked about a lot of the issues surrounding personal injury, given my background and given what he does in his practice too. So great opportunity to have a real interesting discussion, I think, today about some of those issues that we've talked about over the years.
Yeah, it's going to be great. I think hopefully we'll bring some insight to some different, ideas here today, at least, and kind of what I'm seeing that's newer in the market. And hopefully bring, a little bit more insight to today, specifically, maybe a little bit more coding structure and some different language that is being used out there, especially when it comes to, evaluating or looking at how the new carriers systems are evaluating, let's say, claims analysis or even my own documentation now. We talked a little bit about this, but what do we actually know about these, said algorithms that are in there, like the Colossus systems or the DXC technologies, things like that. So hopefully we'll shed a little bit of insight of actually what we do know here today.
Yeah, we will definitely get to all those things because I think it's incredibly fascinating how things are evolving, especially with the intersection of technology now and how that's impacting claims analysis. So as a starting point, your practice is focusing on helping injured people in a chiropractic support mechanism role. I want to ask you a more broad question about just the way personal injury attorneys perhaps make assumptions. And one of the assumptions, I think, is that if a client was injured and is treating, perhaps, the attorney feels like, well, the injury is established. And I'm curious from your take, where's the gap between that assumption and how the modern carrier claims platform actually reads the medical records today?
Yeah. So, a big part of what I do is essentially, I'm here to help attorneys and not only attorneys, but providers kind of better understand how these medical records, coding, imaging, the impairment concepts that we can kind of get from the AMA guides, and then obviously claim evaluations. Essentially, how do all these kind of fit together, right? Because, a lot of these, legitimate injury cases are weakened essentially by the record. It's not that the patient, wasn't hurt. It's just that the record didn't fully support that, right? So essentially, that's why I look at personal injury as, more of a subspecialty in this area. The chart has to work medically, but it also has to hold up into, the real world of the claims environment. So, my work is really about helping medicine and law kind of speak the same language. And I think that's kind of what's missing right now. You guys are the best of the best at doing what you need to do legal wise. And we're really good at documenting and staying on top of, progressing what this injury is actually meaning for the patient and the client so that it makes sense. But we have to make sure that it's kind of an X's and O's game, right? You're only as good as your physician's notes at the end of the day. And when there's no real logic or clarity behind the injury, the patient suffers, right? Not only in results for the care, because maybe we don't actually know what we're treating because it actually hasn't been truly diagnosed. But then on your end, that's where, hey, now the claims adjusters and some of the AI technology out here is going to essentially, once again, filter through those claims and say, there's no real injury case here. These are maybe all pre-existing conditions based on the status of maybe documentation and coding. So it's really interesting.
We'll get back to the show in just a moment, but let me ask you this. What if your firm could scale without adding operational drag? As case volume grows, lean resolution and compliance can quietly slow everything down. Synergy works alongside personal injury firms as an operations partner, managing these processes so teams stay focused on clients, strategy, and outcomes, not administrative details. If you want to understand how firms are handling this at scale, click the link in the show notes or scan the QR code on the screen to learn more. Now, let's get back to the episode.
Good segue into what I was going to ask you about next, which is the difference between injury coding and degenerative coding, because we've talked about this. And for an attorney reviewing a treating provider's records, what are the specific signals that tell you a file is being documented as traumatic versus a chronic degenerative issue?
So, remember, that always goes into the mechanism of injury, right? And the MOIs essentially leads to a derangement pattern. So every injury has a clear shot at a derangement pattern. And, we know what a dog bite looks like. We know what maybe a burn looks like. In my world and what we see in the market now, because, I'm in the non-operative setting, right? I'm in conservative management care. That's kind of what we do, at least in our clinical practice. So, I always ask a question to some of my providers and even the attorneys out there is, what does a spinal injury really look like? Can we define that? Can we really, wrap that up? But, the record is essentially, this helps us connect the injury to the care overall and, what the patient and their, and the benefits in which they're entitled to receive, right? But the easiest way that kind of I can explain, acute coding is this essentially is a current traumatic event, right? What happened? So let's take an auto accident, so that's going to be the acute traumatic event. But degenerative coding tends to suggest more, long-standing, reoccurrent or pre-existing conditions. And that's typically what's being represented in the market because the acute coding strategy, it isn't fully there. The distinction matters a lot in the MVA cases because once a chart starts reading like a chronic or degenerative file, the whole narrative begins to shift. And you guys know that. But you essentially just handed the defense now the room to argue these pre-existing conditions or non-specific pain, age-related findings, which we hear this all the time. That's just because of the documentation is lacking. But the whole narrative begins to shift at that point. So we need to really figure out and interpret the causation standpoint from a treatment standpoint and the overall supportive care. But ultimately, if the provider believes the patient is dealing with a current traumatic injury, the chart needs to preserve that clearly and early on, because what is coded, you guys know, that is what the case becomes.
Yeah. And, what I've seen over the years in looking at medical records when it's an MBA is, terms like low back pain or cervical pain. And it's, almost every personal injury file has language like that. Why is that kind of documentation such a problem and what should be there instead?
I think overall, pain tells us how the patient feels. That is important, right? But it doesn't fully tell us what is actually injured. So then we have to really get down to the nitty gritty of, true proper injury diagnoses. So like you said, terms like low back pain, the cervicalgia, the neck pain that we hear, or even just general base headaches, they're appropriate and they should be a part of the chart, but they need to be a little bit more specific. But by themselves, they do not build a strong injury narrative, especially on our end. That's something that we do not teach, and I don't teach that to my attorneys or my providers out in the market, that's for sure. But they need to tell us whether the problem is ligamentous, is it a disc injury, neurological, muscle instability, all those different factors, right, that actually have more significance on, maybe this is going to lay into what we're going to be doing a treatment-wise and justification for medical necessity on, imaging strategy and things like that to get a clear picture of actually what's going on with the patient. But this is where essentially, the ICD-10 guidelines on my end come in, which these are the diagnosing codes that we use. And we're always referencing these as well because things are always changing. But we use the ICD-10 expert physician coding guidelines, and these are out in the market and they're readily available for physicians and our attorneys. But I don't need you guys to be expert coders or expert diagnosis strategies, because I think there's a lot of doctors out there too that are still working on it, including myself. We always can get better, right? But once the provider has enough information to be able to actually identify the injury, then the chart should move more, I guess, beyond the symptom language, right? And start actually describing the injury itself. So a stronger record really isn't built by adding more of those symptom codes on it. We have to be even more specific when it comes to the diagnosing. So it is built by using the right codes at the right time with the right clinical support. So, remember, pain language may describe the complaint, but injury language is what explains the case. Over and over again, we preach that all day long.
Well, since you brought it up, either a hypothetical case or an actual case that you've been involved with, obviously not giving away any confidential information, can you walk us through what an ICD-10 diagnosis timeline looks like as a story? What does a defensible, acutely coded record look like from the day of the crash through MMI? What does that look like?
Obviously, that's long one here, but let's try to simplify it. We need to find, first of all, the mechanism of injury, MOI, right? What actually generated that? In the ICD, there's very specific language as acute traumatic language, and these are essentially what we call like S codes, right? And M codes are more in our land of musculoskeletal care, because once again, we're in that non-operative space. But there should be charting as far as what's going on with the acute language, and then those symptoms to match what's actually going on there. So if we have, what we see mostly in the auto injury space is, whiplash, right? Or maybe a sprain strain code that is typically tied to that. And then we have assumed symptoms of muscle spasms or mild spasms in there, maybe cervicalgia thrown in. But now with, what we're getting into is that might be okay as placeholders in the beginning of the record, because they're showing acute injury, but now we actually have to start forming the kind of causatory language here as far as what's actually going on with the patient. So, some of those generalized, pain codes are going to be okay in the beginning until you get down to the nitty gritty of actually a definitive diagnosis. So now what we're typically seeing on our end is, there's more and more layers of, AI technology in this medical legal space when it comes to actually looking at radiology reports for clear objective data, right? So even when we're going out and sending the patients for early MRIs, do we have that justifiable early on in the record with numbness, tingling complaints, focal neurological deficits, very specific to dermatomal changes that we recognize in the body from more of a neurology sense? And is that going to dictate an MRI on my end? Most likely. But when I get that MRI back, how are we going to diagnose this? Are we going to diagnose this based on the trauma? Is it going to be a traumatic disc injury, an acute traumatic disc injury, or acute traumatic nerve injury? Or are we going to stay with a little bit more of a pain language or degenerative coding and kind of maybe aim for what we're seeing on the MRI? So that's essentially what a lot that I see, that is, at least on my case reviews, is physicians are, in my space, using the MRI to then capture their diagnoses, but not really capturing the diagnoses in their medical record. They're simply just reverting back to the MRI only because they're kind of stuck, right? And that's what the market has, wanted over these years, is solely MRI. But now the degenerative language and pre-existing condition ideology out there, it's really high, especially in the carrier realm. So if we can identify early on with symptoms, diagnosing in the clinic with orthopedic assessments, and that actually follow real medical necessity, now the language is changing because we're actually suspecting this in our diagnosis strategy when we're actually seeing the patient one-on-one. It's all being recorded, of course. So that's higher medical necessity for what we want to do with the patient.
Well, so when you have imaging and neurologic finding and diagnosis codes, and they're living in separate silos, how should attorneys think about aligning them so that the record reads as one coherent injury rather than separate, distinct findings that perhaps doesn't tell the story?
That's always a tough one, right? And it really depends on, the type of attorneys and their practice and how they actually work these cases up. But the coding timeline is really the life cycle of the injury. So, I tell attorneys first, let's start by asking the simple question, go through the chart. Did this actually preserve the injury as an acute trauma early on in the case? From there, I want to know whether the provider identified the actual tissue involved, whether there's objective findings, and whether the diagnosis kind of evolved, logically over time. I also want to see whether the diagnosis and some of the treatment, we talk about some CPT codes as well, imaging, and, if the prognosis also tells the same story. So you have to capture it at different lenses and angles here. But, the big red flags are, pain only charting, those vague diagnoses, no clear, MOI, no progression for the patient. The biggest thing now is function. Insurance carriers are really looking at function and ADLs and capacity for these patients because, chronic pain is running rampant in our society, and it starts with neck, low back, and chronic headaches. And especially in whiplash cases, and severe ones, the data and the research shows us that, hey, there's about a 50 to 60% chance that, hey, this patient is going to have chronic pain long term. So, we just want to make sure that, the chart isn't drifting too early into degenerative language. Once again, but it has to contain, a long list of codes, but, several of them are basically repeating the same complaint without separate exam findings. So there's different strategy that I kind of teach in there in our injury decoded program, and some of my local CLEs that we do in this Orlando market, at least, on kind of how we identify, some of those red flags for the providers and the attorneys.
So is that ADL impact something that's really important in terms of charting? Is that something that you guys focus on in terms of your patient interviews? Because I'm assuming that that's all self-reporting of the patient in terms of what limitations they have and what they're experiencing.
Yeah, exactly. We call these outcome assessment tools, or OATs, essentially. And we also have two other big ones too. We call these loss of enjoyment of life factors and duties under duress, right? LOE and DUDs. These need to be documented early on, then maybe midway through the case, depending on how the patient is responding. And then also at the end, of course, when we're kind of deciding on MMI strategy or, supportive versus maintenance care for the patient long term. So, those are huge value drivers according to, the AMA and kind of what their placement is on permanency impairment and restrictions. But obviously for us as clinicians, I want progress, right? I mean, I want my patients getting better. And even though these are still pretty subjective, right? They've been used for a long time with data collection. And there's a lot of published research on a lot of these, like the Oswestry low back pain scale, headache disability index, and things like that are two that we can just reference. But those give us a good idea of where we're at with treatment for the patient. Are they actually responding to care? Or do we need to go ahead and now get multidisciplinary or interdisciplinary providers involved? Do I need to get ortho involved, neuro involved, or pain management or neurologists, right? So that's how we use some of the outcome assessment tools. But yeah, they look at that and they, what we know at least is they weigh that pretty heavily. Because long term, they don't want to have to pay for chronic disability for a lot of these injured patients.
In terms of causation, what specific finding, sequencing, or phrasing tends to hold up under carrier review and what tends to collapse? Meaning, like, how do you ultimately make sure you're pinpointing causation back to the accident?
Yeah. So, once again, that's all starts with the diagnoses and how the provider's actually documenting these injuries. Yes, you want to be able to show structured progression all the way through, but early on in the beginning, we need to have, acute injuries. We go through different phases of healing as well for soft tissue injuries. I think, hey, the patient was involved in a car accident. Insurance carrier says, hey, you have 6 to 8 weeks to repair the soft tissue or we're going to cut you off. That is maybe due to pre-existing conditions, due to lack of documentation strategy that's on there. But there is something, that we call cluster diagnosing as well. That's kind of a little bit of another flagging system. Is you want to be very specific with the diagnoses. You don't want to have a lot of, kind of random diagnoses codes in there that are representing the same injury. If you have a definitive idea, at least of what's going on right now, you need to make sure that we're diagnosing that. early on, and then also changing up your coding in a reeval or getting into your final kind of case here as your patient is more in a subsequent or sequelae of healing for their body. So, that's another test that they use is, hey, does any of these diagnoses codes actually change? How do the CPT or our procedures, do they line up with those diagnoses codes? Do they track the right way? But midway through, did my prognosis actually make sense? So they're calculating all this data now. Once again, we're learning more and more about, once again, what's in this market and what's actually public to us. Because, everyone is a little bit different as far as the algorithm and the chain that they use. But your ICD diagnosis strategy should change along the way of the case. It shouldn't stay the same all the way through. I shouldn't have an acute injury all the way through if I've been treating this patient for 2 years. It's not acute anymore. So that's when it comes into repetitive coding, repetitive billing, and we probably know what's going on in this case.
Yeah, I know for me and probably many listeners, whether they're trial lawyers or personal injury paralegals or those in the case management role with law firms, the AMA impairment concepts feel very abstract. In kind of layman's terms, how does AMA aligned residual and impairment documentation change what a case is worth at resolution?
The AMA, it's there's a lot in there, and I specifically referenced the 5th edition and also the 6th edition, but I like to reference the 5th edition a little bit more because we use a lot of objective studies that are well represented in the 5th. I know some practitioners who actually still reference the 3rd edition, which don't ask me why, but it's still represented. There's some good language in there, and it's all playable, right? But I explain, this essentially, the ICD helps build that injury timeline. We talked about that, right? While the AMA concepts help kind of explain what the long-term consequences are of that injury and what they actually mean for the patient and also for you guys representing this. So this is where ideas of like impairment, function, right, permanency kind of comes in, the different categories that are rateable. But for us, we want to look at, okay, is this patient, is there incomplete healing here? Is there going to be chronic-based care that this patient is going to need long-term, more supportive care? But this is where it starts moving from, once again, that short-term complaint to a longer-term consequence for the patient. So we talked a little bit about those value drivers, and they're all referenced in the AMA. So, some of the major value drivers I look for are clear acute diagnoses, once again, the imaging to support it, asymmetrical ranges of motion, neurological findings, things that we can actually, test for and be a little bit more prevalent. Objective data now is huge. We need it because it kind of beats the bias of the pre-existing conditions if, once again, it's documented correctly and the patient is actually having those type of symptoms. But one thing I like to also point out on that is, that a stronger record is not built by throwing out more codes into the chart. I just said you can't don't stack the codes there. You're going to get flagged. You're going to get profiled into that system. Is built by building a cleaner, more supportive clinical story. But the AMA helps explain the story of the patient's lost. What is the functional capacity loss of this patient? That's where those ADL markers come in. That's where the diagnosis strategy comes in for this patient long-term. Because remember, if I cannot properly diagnose this patient, how can I properly guide them into treatment protocols and to actually send them out to maybe a referral status as well? So I need to know really, what I'm doing here, because ultimately, I want my patients to get good results and give them the benefits in which they're entitled to, and what you guys are representing.
To back up, if a lawyer inherits a case or simply is listening to this and is already down the path and the case has been documented poorly, how much of that can be repaired downstream, and at what point does damage to the file become permanent based on what has been already done in the records? Let's
say if we're kind of down the hole here, patient isn't getting better. They're still dealing with a lot of their chronic pain and same symptoms from day one of where they've been getting treated. Now we can maybe introduce some new evidence in there, such as maybe different objective testing based on the patient's complaints that probably were not done before. So that's what I would look at. I would look at some of the objective data here and see if things are matching up and making sense, which if we're in that type of case is probably not. And there's a reason why, maybe this patient jumped ship or they want a different counsel. So, for me, looking over case reviews and trying to guide strategy here and even when we get, hand-me-downs, it's like, man, I really wish I was able to work up this patient in the beginning, because I could have really helped them early on. The early on we have a diagnosis, the faster we're able to help kind of clean up, some of those soft tissue injuries in the beginning, which really helps for, more optimal healing, of course. But if we're kind of living it now, let's say 1 or 2 years post, we're dealing with chronic residuals and chronic pain that maybe isn't represented other than symptoms, right? The patient just keeps complaining of that, but nothing is really matching up. So we need to be able to kind of harness in some objective data here and look at maybe a different strategy as far as, imaging goes. So a big takeaway, in this market, and something that I've learned along the way is when it comes to spinal trauma and injury workups, especially in PI in Florida, there's really no standardized process for an injury workup when it comes to treating and triaging these patients in motor vehicle accidents. So what we have done is we've standardized this process, and we understand what medical necessity brings on us, what the understanding of early MRI utilization for patient satisfaction and rates later on with chronic pain. And how we can desensitize this record a little bit. But I want objective data to reign supreme here, when it comes to what I'm looking at. So let me just back up. So if we can capture this patient now chronic-wise, and I'm getting an old record in, is I'm really going to see, first of all, what imaging did this patient have done? That's going to be my number one thing, because most likely they probably just had an MRI or standard X-ray views. I want very specific X-ray views. I want flexion extension views on every single one of my patients. These are what we call Davy series or trauma protocols. Everybody learns this. Your MDs know this, DOs, chiropractors are trained on this as well. However, it's not being utilized in the market. So that's one thing I always tell my providers that we teach in our program and also my attorneys is, did they get flexion extension views? That's how you assess for whiplash, real mechanism there. That's how you assess for ligamentous injuries, right? We have what we call Nexus guidelines. There are a national X-ray utilization study that we use for trauma protocols, essentially more of an ER or critical care status. And majority of the time, patients are going in there, and obviously they are in pain. So they jump right to a CT scan of either brain, cervical, low back, and then they get discharged out of the emergency room. However, there's probably more soft tissue work that needs to be worked up. There's no blood or guts in the ER for this type of patient, so they send them on home. We just missed early on a great opportunity to assess the actual spinal function and biomechanics here to see, hey, how did this whiplash actually deform the tissue? But instead, what we see in the market, Jason, is early jump to MRI with no real medical necessity for an early jump to MRI. So if I see that right away early on in the record, I know that this probably was not a good workup. All right. But takeaway here is I want flexion extension views on every single one of my MVA patients all day long. Slip and fall, same thing. Okay. We need to assess the mechanics of the spine. We need to look at a true alignment factor. And then we're actually able to produce a more objective data on actually how the spine actually moves into flexion extension. Because majority of the patient's symptoms are not going to be from the disc. All right, majority of those symptoms are going to be from ligamentous injury and damage to that soft tissue area, which is once again one of our main spinal stabilizers. So, however, if we do have a disc in that region that needs to be identified, if I have, let's say, excessive range of motion on a flexion extension view that we capture either from the radiologist or for a third-party examiner, we're going to know, hey, most likely there's going to be a disc injury in that area. Now, once again, medical necessity is going to reign supreme on that. So we just want to be able to really track and follow the record there and understand documentation timelines, understand the objective data that's coming in. Does it match up and correlate with the diagnoses codes that are in there? And then also, does it match with the CPT standards too?
So for everything you've just talked about, what are the best resources or tools for personal injury attorneys and paralegals to have access to or tap into to make sure that they're working with the medical professionals in a collaborative way around these issues?
This is what we're putting together here. This has been a long time coming. We've been really hitting the PI space hard for about 7.5 years now, and is continuously evolving. What my mission is, with our injury decoded program, and if there's any, if there's an opportunity, if there's any local attorneys who are listening to this in this Orlando area, I'm always more than happy to chat about this too. I do offer CLE as well through the Florida Bar. I have multiple courses that we teach on, but we're going to be introducing here very soon. I'm hoping, sometime in July or early August, our injury decoded system. Essentially, the mission behind, my injury decoded is that it's not really about codes alone, right? It's about clarity. It's about alignment, defensibility, better patient access to care, and ultimately better outcomes for attorneys and for us as doctors in here. My number one thing is results for my patients, and that's all I care about. This is our community. We have a great reputation here, and we want to keep that by bringing in good results. But the attorneys, you guys don't need to be doctors, but you do need to understand when the chart is helping and when it's hurting you. And some of the providers need to understand that personal injury is not general documentation. It requires much more intentional record because the stakes are higher, and that's simple. But at the end of the day, the stronger documentation can help both patients and the case. That's really heart of the message that we're trying to send out. But it's not about fighting the insurance carriers. It's just about eliminating confusion in this already very confused market. Confusion is contagious, but creating alignment and improving results we want to make this situation as cohesive as possible, and ultimately make sure that the patient is guided in the proper directions and path.
You've alluded to it several times, and I want to double click on it now. I've got several articles I've written in my Peak Practice newsletter talking about how AI is being overlaid with some of the carrier systems that analyze injuries, systems like Colossus, and with carriers now seemingly relying more and more on these types of systems as part of their claims platform to triage and value demands. In practical terms, what are those systems scoring inside the medical record, and what do they ignore typically?
Depends on their, their proprietary data that they have. You referenced Colossus as one of the bigger players out there, right? There's Injury IQ, there's Medico, there's different IBM. IBM has a big one out there too. And their internal workflow and how they evaluate claims is all different. And I'm not pretending to know the exact scoring logic once again on every single one of these platforms, but we're just speaking on once again what is publicly known. And I always throw that disclaimer out there because it's changing. It changes every single day, every single minute on what they're seeing. So what I'm speaking about is once again publicly known, but at a high level, insurance evaluation systems, including Colossus, these type of models, and are essentially the technology-assisted platforms that you preach about. I know you're big into AI. You're working on some really nice systems yourself, but generally assesses what is documented in the medical record, not what is assumed. So we need to make sure that everything is first documented on there. Remember, we talked about AMA and what some of these main value drivers are. They pump a lot of this data through from the AMA and ICD coding language, and they have to make sure that everything is representing. But the number one thing that it's going to be evaluating is the injuries, okay? But they're not reading the file the same way a treating doctor or a trial attorney essentially is going to be reading it. They're looking for structured inputs and supportable documentation on every single thing that I am doing. But they're looking at the coding, diagnoses, treatment duration, frequency of care. This is too where maybe IMEs start coming in as well. Those independent medical examiners that are saying, all right, you're coding all this stuff. Things aren't really making sense. I'm going to get sanctioned out to see if this patient actually has pain, or they're actually, does this record actually prove that this patient is injured? So we want to make sure that, early on that some of those main value drivers on there that are referenced, and this is what we do with every single one of our patients. Obviously, number one is injuries. Two, we're looking at functional capacity and those different index. We talk about loss of enjoyment of life, duties under duress. Is there any main impairments that just happened from more of this acute injury as well? But they're looking at quite a few things. But in practical terms, I mean, the quality of documentation becomes a huge driver of how the claim is going to be interpreted. First of all, but if the file looks like a short-term sprain with like minimal follow-up, then it may be viewed very differently from majority of what my files look like. So we want progression into maybe ligament dysfunction, a disc pathology, radiculopathy codes. Is there any kind of sequelae conditions? Is there anything that's maybe impeding the patient from actually getting better? Is there pre-existing conditions? There's comorbidities listed. All these things matter, and they all tie in kind of a different value that once again, the AI or the machine on that side is then going to find a little bit of a rating. Okay. So the record is no longer really just saying that the patient was hurt. It's just showing that the injury had measurable consequences over time. So that's what it likes to see. It likes to track progress through the coding strategy because it's data. Remember that. It's data, data, data. So coding strategy and the data input, and when you're looking at S codes and traumatic injury codes versus more degenerative language, once again, if degenerative is early on in the file, then we have already lost. The patient lost. The benefits in which they're entitled to, may be shutting down. But these systems, essentially, they reward structure, they reward consistency, and they reward supportability, which is medical necessity. So that's what they reward. But if the record is vague, inconsistent, fails to connect to the conditions, to the original trauma, these are going to be undervalued regardless of what the patient is actually experiencing. So once again, it puts the patient in a bind, not necessarily the doctor, because then the doctor is going to just move on and treat another patient, right? But once again, technology evaluates the record that was built, not the severity. So we need to basically create a nice reward structure by documenting properly, once again, to get the clients and our patients the benefits in which they're entitled to.
So with what is going on with technology and claims practices, if you look 2 to 3 years out, what should personal injury firms be building into their intake, their treating provider relationships, and their case workups to stay ahead of how carriers are going to value claims tomorrow?
It's understanding simply, the patient that's in front of them clinically, right? And that's where communication, I think, with the physicians and communication with other providers out in the market really help this. So I know, we do attorney check-ins and I let them know, hey, this is what's going on with our patient, but we want to make it clear and simple and let them know what's going on. We are big on medical necessity, once again, and following the kind of path of command there, and big on guidelines and consensus of actually what these injuries are. So within visit 2 or visit 3, at least in our clinic, I know if this is going to be a permanent impairment for this patient. I'm going to know if I have a rateable condition on this. So think about between a 5 to 25% whole person impairment rating, basically off a 3rd visit. However, my goal is to rehabilitate this patient. Okay, that's my number one goal, is to rehabilitate and try to stabilize this patient. So although we may have some significant findings here, we're going to be able to still reference, our guidelines and the AMA and what is going to be trackable for us when we reach maybe MMI. And once again, getting the patients the benefits they're entitled to. So, strategy for attorneys, paralegals, case managers is going through the record, identifying acute injuries, looking at CPT codes and the billing there. Does it really match up? Or are you seeing the consistent language over and over again? I know the notes that I review, the language is consistent, and those are flagged. Those are going to be flagged in the system all day. And they should be flagged in an attorney office, and they should be flagged on the patient as well. Now there does have to be some consistency with treatment, right? Because you want to know, it's just like working out. You need to see if something is adapting or not. How's the patient responding or not? So some things do have to be consistent, but really where the differentiator is, how are they in the, that re-exam? Do those re-exam codes change, or is the same language, is it still acute during this re-exam process? So it's just a little bit of a better understanding and communicating, the overall logic of what actually am I communicating to the attorney? How can the attorney communicate this to the patient as far as settlements and all that stuff goes on your end?
So you've got a lot of experience with injuries and you've been an athlete all your life. I'm curious how all of that plays into how you go about your treatment of people that have been involved in these kinds of unfortunate events. Of course, I know, and you know, that I know this very intimately because I was struck by a car back in 2016. And I know, the way you've worked with me, I feel like you're very in tune with all of that, whereas some practitioners aren't. I'm just curious about your just overall philosophy based on your experience and how you incorporate that into your treatment of this specific population.
I think, injuries in general, they're always tough to deal with, and I've been an athlete my entire life. I played Division I college basketball. I've had 5 hip surgeries. I've blown out both my knees. It's been a little bit of rough for me, but what got me into this was all my injuries in the first place, and my own healing capacity and what I was able to do with the practitioners and providers that I was able to work with and how I was able to, succeed in my own health. So I wanted to bring, something a little bit different to the table. And that's why, I kind of got into chiropractic. And, what I do is, it's not just as simple as chiropractic. I hold multiple board certifications in what we do: chiropractic, physiotherapy. I do a lot in the functional medicine space and human performance. That's really what it's about, and even when, there's a time of injury, I'm here to support and be that teammate for that said person, if there is an injury, and always like to say too is, the physical component of healing is usually, a lot easier than the mental aspect. I'm not only here to help, my patients guide, physically, but also here to support them mentally as well. Because, I've been through the trenches myself. I understand these things. It's not easy to rehab and have to come back, from an injury or, have your entire life disrupted. It creates, a lot of stress in different scenarios and in all people. And, we all have our own journeys in life. And, unfortunately, an auto accident or, traumatic injury, it's going to be a part of that process. But we want to make sure that, I'm always doing the best by my patients. And we fully believe that, all of our practitioners in here.
Great point you just made about the emotional and psychological injuries that I suffered were definitely much more challenging to recover from than the physical side. After a few months, most of the injuries, my dental injuries took a lot longer to fix, but the emotional side of it took longer for me to figure out, hey, I needed to seek some professional help because of just anger issues. Because for me, it produced a lot of anger directed at the driver. And how did you not see me in a bike lane? I've got lights on my bike and all those things. And you start to blame yourself a little bit for it because, it's just human nature. Like, why didn't I see him, or why didn't I stop? Or anyway, a million things go through your head and dealing with all of that. And for me, just having flashbacks once I got back on my bike and having to ride by the same spot that I got hit because it was, on my regular route, like all those things are probably the toughest part of getting over this kind of event when it happens to you. And it's a really good reminder that, these injuries, they're called personal injuries because it is intensely personal when you've gone through something like this.
I know myself too, going through it mentally, things can manifest differently, right? The manifestation of pain and different symptoms and, you just not being yourself, it really changes, the people around you. It changes everything, the dynamic. And one thing we always want to get right is what's going on up here, because once again, it's going to allow that person the capacity to heal a hell of a lot better, hell of a lot faster. And we know that we're doing our job there as a good teammate. So there's a lot that goes on into that mental component of it. But, we like to have, we have a lot of different resources and educational materials. We actually have a mental health counselor in the office who's a very high performer herself. So, if we ever need any referrals, we have a great referral sources all around the local Orlando community too. But we want to have that outlet for people. I think it's definitely misunderstood and once again, not really talked about too much in this PI space.
Well, you've been very generous with your time today. One final question. It's pretty open-ended. I ask it of all my guests. As a medical practitioner who is involved in the personal injury space and treating people who've been injured, what's your view?
What's my view on this is I think we can all be better. Let's all continue to grow, continue to evolve, continue to treat our patients, our clients better, and continue to get results.
Well, Dr. Shantz, if anyone has questions about anything you've talked about today, what's the best way to get in touch with you?
I can also send you the hyperlink or just my personal email. That's always fine. I like to engage with, once again, my community and, some of the other attorneys that we get to work with all around the U.S. But this can be my personal email. We can do drchance@winterparkchiro.com. It's just drchance@winterparkchiro.com.
And we'll include that in the show notes. And thank you again, Dr. Shantz, for joining me today on the podcast. And we'll see everybody on the next episode of Trial or Review.
If today's episode gave you a new perspective on how your firm operates or sparked a useful idea, consider sharing it with a colleague and be sure to follow the show so you don't miss future conversations with leaders across the personal injury space. Trial or Review is brought to you by Synergy, a strategic operations partner helping personal injury law firms resolve healthcare liens more efficiently. If you're looking to accelerate case flow and allow your team to focus on high-level legal work that moves cases faster, consider partnering with Synergy. I'm Jason Lazarus, and I'll see you in the next episode.